Hi, my name is Benjamin Emery. I'm a PGY1 at the University of Tennessee, Chattanooga, and I'm here to share an interesting case of a patient who presented to our ED with HaNDL, or Syndrome of Headache and Transient Neurological Deficits with Cerebrospinal Fluid Lymphocytosis. My hope is that those listening can walk away having learned the presentation of HaNDL, which, although there's significant variation, has some common features which aid in the diagnosis. And secondly, I'd like to share a strategy for differentiating this condition from other similar diagnoses like stroke and hemiplegic migraine. And thirdly, emphasize how important it is to obtain a detailed history in these patients. So to get started, our patient is a 27-year-old Caucasian female presented with 1 week of gradually worsening frontal headache, nausea, and vomiting. She was prompted to come to the ED after an episode of peripheral vision loss and increasing somnolence. Only history is frequent otitis media and self-reported Hashimoto's. We reviewed her records and discovered she had presented almost exactly a year ago with almost identical presentation of frontal headache, photophobia, mild nuchal rigidity, and confusion after 3 days of influenza virus upper respiratory illness. At that time, LP showed white count of 953 with 99% lymphs, glucose of 65, and protein 99. She was diagnosed with viral meningitis, and her symptoms resolved in a couple weeks. On exam, she was uncomfortable but non-toxic, left-sided hearing deficit, no mastoid sinus tenderness, no neurologic deficits. LP showed a normal opening pressure, white blood cell count of 625 with 95% lymphs, glucose of 63, and protein of 44. Her meningitis encephalitis panels, CSF cultures, RPR, cytology, it's all negative. CTA and MRI brain with and without contrast showed only a large left mastoid effusion. Her course was pretty benign. Within 48 hours, her headache significantly improved with symptomatic management. She was diagnosed with HaNDL and sent home. Interestingly, at a subsequent clinic visit, she reported continued headaches and nausea, and with further inquiry, we also found that prior to admission, she had actually also experienced expressive aphasia and motor deficits, which were not details that we had obtained during her hospital stay. We feel that this is an important case to highlight because headache is such a common presenting complaint and HaNDL is an important differential for those presenting with neurologic deficits. So HaNDL is a self-limited aseptic meningitis. It features recurrent episodes of severe headache accompanied by neurologic deficits and lymphocytic pleocytosis. It is also called pseudomigraine because the pathophysiology is thought to be the same cortical spreading depression. 50% of patients have a viral prodrome, and some viruses have been identified in the CSF. So the leading theory is that a viral-triggered autoimmune response causes leptomeningeal vasculitis. Importantly, it's a diagnosis of exclusion. Given its variable presentation, it can be difficult to differentiate, so we'll walk through that. Management's very simple. It's supportive treatment, and it's self-limited, so important to identify early on to avoid chasing other diagnoses. The ICHD3 criteria require hemiparesis, hemiparesthesia, or dysphagia to be present and lasting greater than 4 hours, but patients can present with other neurologic deficits like aphasia. In many patients, imaging is negative, but MRI may show a transient leptomeningeal enhancement and reduced venous signal, representing focal hypoperfusion, in contrast to the enhanced venous signal of migraines. The CSF is very valuable to help in the diagnosis. Patients have a lymphocytic pleocytosis, usually with more than 100 white blood cells and greater than 90% lymphocytes. Opening pressure and protein are elevated in most cases, and glucose is usually normal. Our patient was a bit of an anomaly, had a very elevated pleocytosis, normal opening pressure, normal protein, which highlights the importance of looking for the triad of headache, transient deficits, and the lymphocytic pleocytosis. As I mentioned before, an important goal is to differentiate HaNDL from other similar conditions, so let's go briefly through the chart on the right hand. Hemiplegic migraine, perhaps the most similar symptoms, but LP will be the key differentiator here, as it won't have a pleocytosis. MRI can also be useful, as we mentioned. Mollaret's, focal deficits less common. HSV is also useful to diagnose Mollaret's in the CSF. Drug-induced and bacterial meningitis have a typically neutrophilic predominance in the CSF, and the neoplastic can often be differentiated based on cytology. To summarize some key points in this presentation, HaNDL is a self-limited benign condition, presents with headache, transient neurological deficits, and lymphocytic pleocytosis, and it's this triad that differentiates it from stroke and hemiplegic migraine. Imaging and lab testing alone are not definitive. These have to be interpreted alongside the clinical presentation. And then thirdly, it's crucial to elicit the detailed history. This includes symptoms that may have resolved prior to presentation. I'd like to thank my faculty, staff, and colleagues at the University of Chattanooga for making this possible. Thank you all.